Ladies and gentlemen, esteemed guests and distinguished panelists, a very warm welcome to this remarkable conclave on a topic close to our hearts, living with cancer, a journey that makes you stronger. Before we delve into the depths of this crucial discussion, I would like to acknowledge and commemorate a significant event that brings hope and inspiration to countless individuals around the world, National Cancer Survivors Day. This day serves as a powerful reminder of the strength, resilience, and determination displayed by cancer survivors and their loved ones. I would also like to acknowledge and thank the Times of India Group for organizing this conclave. Allow me to take a moment to introduce myself. I am Dr. Arjun Dang, CEO and partner and a GI and liver pathologist at Dr. Dang's lab, a passionate advocate for healthcare and an ardent believer in the power of knowledge and awareness. Today, I am honored to be your moderator for this conclave, where we will navigate the complexities and triumphs of living with and learning about tools to fight cancer. Our conclave, aptly named Living with Cancer, a journey that makes you stronger, resonates with the collective experiences, struggles, and victories that individuals and families touched by cancer face every day. Together, we can embark on a profound exploration of the challenges faced by cancer survivors, the importance of early detection, and the key role it plays in their survival. In today's session, Surviving Cancer Early Diagnosis is the key. We will delve into the crucial aspect of detecting cancer at its earliest stages. We will explore the impact of early diagnosis on treatment outcomes, quality of life, and long-term survival. Through the expert insights and personal stories shared by our distinguished panelists, we hope to shed light on the significance of proactive screenings, increased awareness, and the potential life-saving benefits they bring. This panel discussion is an opportunity for all of us to deepen our understanding, challenge existing notions, and foster a collective commitment to promoting early cancer diagnosis. Let us remember that this is not just a discussion, it's a call to action. Together, we can make a difference. We can empower individuals, families, communities to face cancer head on with the weapon of early diagnosis. Through knowledge, compassion, and collaboration, we can pave the way for a brighter, healthier future. So, a quick introduction to the panelists, and we are super privileged and honored to have such a distinguished panel of experts joining us today for this panel discussion. Dr. P.K. Julka, sir. So, Dr. Pramod Kumar Julka, recipient of the prestigious Padam Shri Award, serves as the Principal Medical Director of Medical Oncology at Max Healthcare. With over 4 decades of experience in cancer treatment and research, he has made significant breakthroughs in the field. His expertise and contribution to cancer care in India are unparalleled, treating over 90,000 patients and pioneering innovative treatments. Dr. Harsh Mahajan, sir. So, Dr. Harsh Mahajan, the founder and chairman of Mahajan Imaging and Labs, is a renowned figure in the field of integrated diagnostics, radiology, and nuclear medicine. As a Padam Shri awardee and former honorary radiologist to the President of India, his expertise and leadership have made a lasting impact in the medical community. He's also the chairman of Kapil AI and the Department of Nuclear Medicine and PET-CT at Sir Gangaram Hospital. Dr. Ishita B. Sen, ma'am. Dr. Ishita B. Sen is an esteemed nuclear medicine physician with over 25 years of experience. Having worked at prominent institutes such as Indraprastha Apollo Hospital and Sir Gangaram Hospital, she currently serves as the Senior Director and HOD of Nuclear Medicine at Fortis Memorial Research Institute, Gurugram. Her expertise lies in nuclear oncology and molecular imaging, particularly in PET-CT imaging and nuclear theranostics. Chavi Mittal, who is a cancer survivor, and thank you for being here. It's a pleasure to have Chavi Mittal, a cancer survivor. A personal journey of triumph over cancer will bring a valuable perspective to our discussion. Together, our panelists bring a wealth of knowledge, experience, and groundbreaking contributions to the field of cancer diagnosis and treatment. We are confident that their insights will provide valuable perspectives on the significance of early cancer detection and survival. So my first question, without much ado, is to Dr. P.K. Julka, sir. And sir, thank you for joining us today. It's an absolute honor having you here.
Thank you.
In recent years, sir, significant advancements have been made in cancer diagnosis and treatment, leading to improved patient outcomes. One notable breakthrough is the development of what we call as precision or targeted medicine, which involves tailoring treatment treatments based on the patient's specific genetic profile. This approach allows for targeted therapies that can effectively attack cancer cells while minimizing damage to the healthy cells. What are the latest scientific advances in cancer diagnosis and treatment related to precision medicine? And so, how are they improving patient outcomes?
Yes, this is a very good question and my favorite topic of precision oncology and personalized medicine, because I always used to say, I'm talking of 1980s and 90s, when there were, treating breast cancer, lung cancer, or other solid tumors. I used to say that no two patients are alike in the same stage. Suppose we take stage 1 breast cancer, no two patients are alike. They are different in each respect. Even lung cancer, if we take the example, no two patients will be alike. It would depend on their phenotypic profile, it would depend on their genotypic profile, and nowadays we have the options of doing their molecular horoscope, I call it. We talk of horoscopes, and now we talk of molecular horoscope, in the sense that we do molecular profiling of the patient, and then the genes which are expressed, tumor suppressor genes and the oncogenes which are expressed, depending on that, we treat the patient. We have certain tissue agnostic tests. Now, let me give you an example. There is a metastatic colorectal cancer patient with me who has crossed 5 years of metastatic colorectal. His MSI on further molecular profiling, his MSI, we call it microsatellite instability, was high, and he had KRAS mutation in the exon 2, and he, for MSI high, I gave him immunotherapy, which is in the form of pembrolizumab or Keytruda, and then for KRAS mutation, I gave him bevacizumab, simple drug, which is available in India. And for to make the tumor hot, we call it hot by immune, to make the tumor more immune, gave capecitabine. And the patient is living today after 5 years, and he is hale and hearty, doing normal work, and quality of life is excellent. This is the difference made by molecular profiling and precision medicine. I just gave you one living example, and we are going to publish this. This would be the first case in the world treated purely on molecular basis. And he had been treated earlier, and he had lung mets which were not resectable, and he had multiple mets, and all mets have disappeared. So I'm going to publish this case because in JCO Precision Oncology, which we call the best in precision oncology, the best journal, which I would be aspiring to. This is just an example, but otherwise we are treating all the patients, most of the patients, on precision oncology. Because I'll give you multiple examples. Lung cancer patient had ROS1 fusion. There are mutations, there are fusions. These are two different things. So patient had ROS1 fusion, we gave him a drug against that, and 3 years patient was all right. It was a metastatic lung cancer. And after 3 years, we did another molecular testing. I generally used to get it done from Foundation One in the US, which is the highest lab, FDA approved lab. And then I found that ROS1 has disappeared, So once that had disappeared, I put him on chemotherapy, and the patient lived for more than 5 years.
So, sir, there are several cutting-edge imaging technologies that have revolutionized cancer diagnosis and treatment. One notable advancement would be the integration of various high-end imaging modalities. And these modalities have significantly improved the sensitivity and specificity of cancer detection compared to the traditional standalone CT or MRI scan. So, could you teach us and tell us a little bit about what are some of the latest imaging technologies being used in cancer diagnosis, and how do they compare to the traditional methods, say 10 or 20 years back?
Thank you very much, Arjun. It's an honor for me to be part of this conclave, this very important conclave. And since most of our audience is going to be lay people, I will not go into great technicalities, but CT and MRI, which have been around for over 3.5 decades, have really been the game changers as far as most disease conditions go, including cancer. And what has happened in both these technologies is that from what machines and what technology and what capabilities we had, say, in the late 90s, even in the 2000s, to now, there have been great advancements. Speed of both CT and MRI has become very, very fast. Resolution has improved. There are newer ways, newer sequences, newer coils. So the technology has undergone a sea change. And hence we are able to pick up disease very, very early. And also when we are looking for spread of disease in different parts of the body, both CT and MRI still continue to hold their own, play a major role. Now, where the new technology came, even PET scan as we know it, positron emission tomography, has been around for nearly those 35 years, but it is only about 20 years ago when CT scan and PET scan were actually married in a way and became one technology, where CT would show us the structure, the PET scan would show us the functional aspects, the metabolic aspects of disease. That this actually, since the early 2000s, has been the fastest growing technology as far as imaging goes. And also, even though it is not very specific, but it's highly sensitive, I actually tend to call it a Brahmastra, that you inject isotope and do a PET CT, and wherever there is abnormality, be it cancer, be it infection, be it even inflammation, it'll point out to those areas. And hence this also has been a game changer in very precisely showing us the extent of disease. When we talk of cancer, we talk of the stage of cancer, and there stage 1, stage 2, the early stages, if you're able to pick those up, the diagnosis, make the diagnosis early, you can do excellent treatment. It is also less expensive, less traumatic for the patient, and the results are excellent. When it's stage 3 and 4, as Dr. Julka has said, we talk in terms of 3-year survival, 1-year survival, 5-year survivals. And even there, the extent of disease in the body is best demonstrated by PET CT scan, where we do PET, where an isotope is injected, and a CT scan where you may or may not inject a dye or a contrast at the same time. Even though in absolute terms this appears expensive, it is about 25,000 rupees for a scan, but if you look at the cost versus benefit ratio, then it's heavily weighed in favor of this, because Dr. Julka was talking of precision medicine, and there again, it is important to know, based on the genomics and the genetics of the tumor or of the person, as to how to treat. It's equally important to know where all the spread of disease is present. So I would say we are today in the era of integrated diagnostics, where pathology, lab medicine, genomics, genetics, and imaging, be it using CT, MRI, ultrasound, X-ray, or PET CT, gamma camera, so much information is all brought together to achieve the goal of precision medicine. And here also, we should talk, I think, of predictive medicine, which is based on the risk factors that a person has, we divide the general population into those who are at high risk and those who are at average risks. And the high risk people need to be screened very, very diligently. And as we go along, we'll talk further about it. Thank you.
Dr. Harsh, may I interrupt? Just
Please go ahead.
Difference between PET CT and PET MR. This is frequently asked by the patients.
So PET MR came in about 15 years ago with a lot of promise, and somehow that promise has been belied. It may have some role to play in malignancy of the brain, in malignancy of the prostate and the breast, but actually what happens, most people have already had an MRI done before they are sent for a PET scan. And because of that, if you see the growth of PET MRI globally has been very, very slow. And even the theoretical advantage that we felt that this technology would have, it hasn't actually lived up to that potential. That's point number one. Point number two, when we do a whole body imaging on a PET CT or a PET MRI, the lungs form a very, very important part where we look for spread of disease or metastasis. And that still, MR is not good at all for looking for lung metastasis or lung diseases, where at times even an X-ray may be able to show something which MRI may not be able to pick up. So that's where we still have to undergo a CT scan for the lungs. And this is another reason why PET MRI hasn't come to the forefront. So I would say that still the go-to examination, and this I'm talking not only in the Indian scenario where we have hardly any PET MRIs, but even the global scenario, even the Harvard Medical Schools and the Stanfords of the world, there also PET CT is still the modality of choice for most cancers.
Thank you.
Thank you.
Thank you, Dr. Mahajan, for that. So, Julka sir, we lost you in the middle, but you were talking about personalized medicine and how a cookie cutter
I don't know what happened
work.
Yeah,
yes. If you have any other points, sir, for that precision medicine answer.
Yeah, I was talking about certain patients whom we have treated by according to molecular medicine technique and purely on molecular oncology. And a molecular oncology basis has really revolutionized the treatment now, because the treatment where we used to find that nothing can be done, now today only, there is a breast cancer patient triple negative. Triple negative means ER, PR and HER negative, and who had been on several lines of chemotherapy, but patient again relapses. Then we have a final atom bomb for her, and I call it an atom bomb. Why? Because that is sacituzumab govitecan. It is an antibody drug conjugate. Nowadays we are having antibody drug conjugate, means that antibodies are attached to the drugs, and the antibody attaches itself to the, suppose HER antibody is against HER2 gene, it attaches to the HER2 external domain and gives the drug there, and the action is much better. And we have several drugs which are coming up. Sacituzumab is for basically triple negatives, and we have Enhertu for HER2 positive and HER2 low. And now you can see how it has revolutionized. Now I'll give you an example of breast cancer. Why I'm giving you this example? Because many people feel that majority are hormone receptor positive cases, HER2 negative. Now HER2 negative also, we are dividing them into HER2 low or HER2 0. So that also makes a difference. So in metastatic setting, in hormone receptor positive, we are giving CDK4/6 inhibitors plus hormone therapy, and that is making a difference, lot of difference. Now patient taking one CDK4/6 inhibitor, and if HER2 is low, that means 1 plus or 2 plus, which is negative on fish, and then we give it another CDK4/6 inhibitor, or we could give antibody drug conjugate in that case. So nowadays, the antibody drug conjugates have made a lot of difference in the treatment of patients, and we are lucky to, but they are expensive. I know. I'm wishing that they should be launched in India and become cheaper as the days pass by.
Thank you, sir, for those very insightful comments on this precision medicine, and very interesting to know your points also on this. My next question is to Dr. Ishita Sen, ma'am. Ma'am, thank you for joining us today. It's an absolute pleasure having you. So, ma'am, nuclear medicine plays a crucial role in diagnostics by providing functional and molecular information, allowing for earlier disease detection, accurate staging, and personalized treatment planning as well. Ma'am, for the non-medical fraternity watching today, if you could just tell us broadly as a bird's eye view of how is nuclear medicine being used in cancer diagnosis and treatment, and what advantages does it offer over the other imaging modalities that we have?
Thank you, Arjun, and it's an absolute privilege to be a part of this wonderful initiative by the Times of India group on the occasion of the National Cancer Survivors Day. Nuclear medicine is a branch of medicine where we use small volumes of radioactivity to detect as well as to treat cancer. Mainly, we talk about cancer in this context. The beauty of nuclear medicine over other radiological imaging is that nuclear medicine actually tells you about the function, and the changes in function can sometimes occur before changes in structure occur. So you can actually see the very early changes in the molecular level even before you actually develop a big mass. Also, sometimes despite the changes in structure. So a patient has a surgery or has radiation for a tumor, and the normal anatomy or the normal structure may be distorted in these patients. And it's often difficult to find whether there is some residual cancer which is lurking in that region, or has it grown back. So it's very, very difficult clinically to understand whether there is still a residual disease there, or whether it's just post-treatment changes. These are also the scenarios where often the conventional radiological techniques like CT or MRI or ultrasound are not able to give you a conclusive answer. But because nuclear medicine questions the molecular basis of cancer and is able to detect the cancer or the molecular changes which cancer produces at the very, very earliest point, so we are able to detect the beginnings of cancer even despite the changes in anatomy. So that's the beauty of nuclear medicine, is that it looks at the cancer at a molecular level. And as Dr. Mahajan already said, that you can fuse when you do a PET CT, which looks at the molecular basis of the cancer, and you can fuse these images with the very high resolution CT or MRI images. You get a complete holistic picture of where all the cancer has spread, or where it has come back, or how it is responding to chemotherapy. And that is why often the PET CT is the first investigation which a patient undergoes when a diagnosis of cancer is made. And the PET CT, as Dr. Mahajan sir has already mentioned, not just tells you, we've just like in all other technologies, nuclear medicine has also evolved over the years from lesion counting. So earlier a PET scan would just tell you what is the stage of the disease, where all is the disease, is it there only in one side, or has it spread, is there a widespread dissemination of the disease. But today nuclear medicine is more about the molecules which question not just how far the disease is spread, but give you an insight as to how this tumor is going to behave, how we are going to treat this tumor, what are the receptors. So the receptors which Dr. Julka sir was talking about, you can actually visualize some of these receptors, whether it is the Herceptin receptors or the CD20 receptors or the somatostatin receptors. So these are different receptors which different tumors will express, which different cancers will express. And by nuclear medicine techniques, not only can you count the lesions that you know that, okay, you've got disease so much, but you can also see whether these tumors are expressing these receptors, whether you talk about predictive oncology, we can actually visualize and see whether this patient is going to respond to a particular kind of treatment or not. So it gives a lot of insight into disease. It tells us how a patient is responding to a particular therapy. So response evaluation has become a very, very important part of cancer diagnostics and cancer. The journey of a patient is I sometimes my patients tell me that our life goes from one PET scan to the other. So the first PET scan which tells us about the diagnosis of disease, the next PET scan which tells you how I am responding to that particular therapy which I have been given. So again, response evaluation is something which is very, very critical to the management of cancer. So is a patient responding or not responding? Is he, if he is not responding, do we need to change the track? Do we need to start him on a second line therapy? Do we need to change the dose? All these decisions are based on these PET scans. And nuclear medicine, simply because we are able to detect the very early changes in metabolism in the cancer cells, we are the nuclear medicine techniques, whether it is a PET scan or sometimes even a bone scan, they are able to actually detect the changes which occur in response to a treatment. So there is a disease called GIST, and there's a drug which is given for it called imatinib. And sometimes when you give imatinib, the tumor, which is a large tumor, which is a solid tumor to begin with, undergoes a lot of necrosis within and actually swells up and becomes bigger in size. So when you use a conventional technique like a CT or an ultrasound, you will actually see the tumor increase in size. But when you actually do a PET scan or you do one of the molecular imaging techniques, you realize that the tumor has just swollen up because the center of it has died and become liquefied or become necrotic, and that kind of a increase in size is not progression. The patient is actually responding. So this same concept holds true for many of the immunotherapy drugs which we use. So it's very important today to understand how a new drug or each of these drugs which are used for the treatment of cancer, how they are going to, what are the changes at molecular level which these drugs are going to create in the patient's tumor. And that actually serves as the basis for the decision making of whether to continue this treatment, whether to change gears, whether to add on something, whether to change dose. So all these things are based on these nuclear medicine techniques. So nuclear medicine, just by virtue of being able to question the functionality of a tumor, gives you a lot of insight as to how this tumor is responding.
Thank you, ma'am, for explaining it so well and very clear, and thank you for that. So,
Arjun,
Chavi,
may I just add, Dr. Ishita has explained it so very well. Just to tell the viewers that previously, when we were using only a CT scan to determine tumor response, generally it would be at completion of a chemotherapy, which could be 8 cycles, 6 cycles, 10 cycles, that we would repeat a CT scan, and based on that, we would evaluate and determine, yes, the tumor is responding, no, it is not responding. Whereas now, after the second cycle itself, which is, a matter of a month and a half, generally, you can do a PET CT and see very clearly whether it's a responder or not responder. And you don't have to wait for 4 months, 6 months to change medicine in those who are not responding. And so it has made a dramatic difference in overall treatment outcomes, because you know very quickly whether your chemotherapy or whatever medicine you're giving, whether it's working or not. Thank you.
Yes, actually, Arjun, just one more query that Dr. Ishita already explained so well. MR spectroscopy for glial tumors, for brain tumors. Generally, we get it done routinely, at the beginning and after a few cycles of radiation and chemotherapy. So do you feel that MR spectroscopy could be more improvised? Dr. Ishita, please.
I think Dr. Mahajan should be answering this question. He's the MR man of the country.
He is the MR man. Dr. Mahajan,
well, sir, we, as you very rightly said, we do spectroscopy in every case. Yeah. But apart from that, I think the major decision making of whether it's residual tumor or it's post-radiotherapy, post-chemotherapy, post-operative change, the difference really depends on perfusion imaging that is done on MR. So on MR, we do what is called multi-parametric tumor imaging, where apart from all the conventional imaging that we do functional imaging. Just as Dr. Ishita talked about functional imaging on a PET scan, similarly on MR also we do functional imaging, which is diffusion, perfusion, MR spectroscopy, and based on that we give a diagnosis. However, I would say that still in some patients we would end up sending patients to the nuclear medicine department, where despite doing everything on MR, we are still not sure. And then there are specific isotopes which are used apart from FDG. I don't want to go into any technicalities, but we can actually be helped by nuclear medicine and PET scan to determine whether residual tumor is there or not, even though this may be 1 in 10 cases of follow-up of brain tumors.
Yes.
Thank you, everybody. So quickly coming to Chavi, and firstly, thanks for taking the time to be here with us, and you can give a perspective that none of the medical experts here can. So super excited to hear your views on this question. And firstly, Chavi, could you just tell us like a detailed account of your personal journey with the diagnosis of cancer and then the treatment, and including the challenges that you would have faced and probably the lessons that you would have learned, along with how has this experience influenced your perspective on life and the way you approach your health and well-being? I'm sure you have a lot to tell.
That's a lot of questions. But thank you for having me. I'm really excited to be here too. And I'm hearing everything that the good doctors are saying here. But even though I'm a cancer survivor, I think a lot of it is very, very technical and difficult to understand for a layman. One thing that Dr. Julka was just talking about is that depending on what kind of cancer you have, even if you're at the same stage, even if you're, similar in terms of the diagnosis, the treatment could differ a lot. So I think what I feel as a layman in this case is that it just merely depends on, sometimes we eat a certain vegetable and one person responds differently to the vegetable and the other person responds differently. Like somebody will tell you that, radish is really good for you. One person will get gassy and the other will not. So it's in a sense, it's just that the treatment options that there are today for cancer are so many, and it's really good to know that. And I think anybody who is suffering from cancer, the first thing that they need to know is there is definitely an option there for you, which is actually going to be customized for you. So the biggest learning for me as a cancer survivor is that just because somebody else had a tough time or a tougher time doesn't mean that my journey is going to be tough too. You need to be with a good doctor. You need to have faith in your treatment. and you need to know that there is light at the end of the tunnel, and it is in a lot of cases curable. And even if it's not 100% curable, you can live with it, you can manage the disease over the years, and that's a really positive thing, you know. And I feel that most people get really scared with the C word, but there are a lot of people who are living their lives with diabetes, with hypertension. They are managing their diet, they are managing a lot of medication, they are managing the side effects of the medication. So I think cancer is also now a little bit like that, where you can manage the disease and don't be so scared with it. And when I was diagnosed the first time, when I got to know that this could be cancer, I really want to say that my radiologist literally saved my life, because she forced me to do all the tests that there were to understand what this tumor was, because everybody said that this looks cancerous, and I was so sure. As a layman, you know, you always feel that this doesn't happen to you, it always happens to somebody else. So, you know, with that attitude, I wanted to delay it as much as I could. But thanks to her, she really forced me to get all the tests done. We did the tests, and I think your entire treatment and your entire recovery depends a lot on how soon you identify the problem, right? And I think a lot of, like, most of the doctors will talk about the treatment because that is what they do. It's their job to do that, to make sure that the person recovers from cancer. But as a cancer patient, I felt that that a very, very important part of my journey was what my life is going to be post the cancer. How is life going to be after the cancer is gone from my body? Is it going to... Now, since I didn't know, there was no as such a first-hand experience of what happens to somebody after the cancer. I really wanted to know how life is going to be. Am I going to be the same physically? Am I going to be able to do the things that I love? Are there going to be a lot of diet restrictions? Are there going to be a lot of medication? Are there going to be a lot of side effects from the medicines? And all of those questions were there in my mind. But I think because my cancer was diagnosed early, we could get rid of it, and I could dodge chemotherapy. I just had to undergo radiotherapy, and again saying how different treatments, people respond differently to different treatments. I didn't have any of the major side effects of radiotherapy as well. They were pretty well managed, and my life is very good. And you know, just like you said in the beginning of the session, that it is something that makes you stronger. It is definitely something that's made me stronger, and I feel like, you know, once you conquer something like this, there's very little that you cannot conquer. So I think that is my biggest takeaway from the entire journey.
Thank you, Chavi. That's indeed very interesting, and also for so many viewers out there, I think it is that light at the end of the tunnel, and you are a prime example of it. So quickly moving on to my next question to Dr. P.K. Julka, sir. So, sir, what we've seen in the recent past also, and also a very famous Hollywood example also that all of us have seen, is overdiagnosis and perhaps in certain cases over-treatment. And obviously, it is very important to diagnose timely and also with various screening modalities. But sometimes this leads to overdiagnosis, and sometimes there might be extra cautious people and physicians who might go over the line and do something radical. Obviously, at the end of the day, it is the patient's choice. But your guidance on this and how to still be very proactive with all the screening programs, but then avoid overdiagnosis and overtreatment, and to understand the report correctly and the management ahead.
Actually, screening programs, unfortunately, are not prevalent in India as they are in the West. But still, we have certain screening. We have been doing screening here also at Max, and we have been doing screening earlier also in some areas, and we had chosen certain areas for doing screening. And on screening, you can pick up a certain, like lumps are not cancerous. So one should not be scared that if you detect a lump in the breast, it is cancerous. You should go to your doctor, and that is the advantage of screening, that you can pick up early, lump in the breast or lump in the axilla or lump in the supraclavicular neck region, and then you can go to the doctor. And some people go in for FNAC, but we always advocate biopsy of the lump and then see whether it is cancerous or not. It is overdiagnosis, in a less number of cases, because some people are doing screening in rural areas, where we find that, as in the AIIMS, when I was Dean of AIIMS Delhi, then I was part of National Cancer Control Program. And there we suggested that, rural areas, why don't you tell ASHA workers and social workers to do breast self-examination, to teach breast self-examination to the women of rural areas, because breast cancer is the commonest cancer, and next comes cancer of the uterine cervix. So cervix cancer pap smear can be taken even in rural areas, primary health center, and they can send it for reading to microbiologist elsewhere or a regional cancer center. So here we opened 29 regional cancer centers in each state, except Maharashtra has 2 regional cancer centers. So what I mean to say that early detection is the hallmark to cure, because as Chavi already pointed out, if you detect a small lump in the breast, which is low risk, which is at low risk, and then you just remove the lump and do radiation and then go in for hormone therapy if it is hormone positive. Now, so you avoid unnecessary expenditure, and plus you avoid the horror, so-called horror of chemotherapy, which people are afraid of chemotherapy because they feel that is very painful, though it is not painful at all. It has side effects, but it's not that painful. But
so, Doc, I would just like to cut you here and add, just for the viewers, that when I used to go in for my radiotherapy, I used to meet a lot of patients who used to come for chemo, and they were all looking absolutely fine. And in our head, we feel that chemo is a big monster. But all these women, they would come in, get their chemo done, and then go to work. So it's very, very encouraging to see treatments like that, and that chemo is actually absolutely fine.
Yes. Even at AIIMS, I used to do chemo in the morning and tell the patient to go to work and not to go home. And by the time she came back, she used to say that you did the marvelous job by sending me to work, because there is no nausea, no vomiting, nothing, and I have forgotten about my chemo. And that is what, people are unnecessarily afraid of chemo as a, horror thing. It would cause a lot of pain, and even though it is painless. So what I mean to say that if you detect a tumor early, we did a study with Tumor Institute Milan, and we found that in India, we detect a tumor, I'm talking of breast cancer, we detect a tumor of 4 millimeter average, and whereas they detect a tumor of 0.4 millimeter, or even less than that in Milan. So 4 millimeter versus 4 centimeter tumor, that was studied in 80s and 90s. And now we are finding patients coming in early stages, and awareness is increasing. Increasing awareness is most important, that patients should know the signs and symptoms of cancer, and they should come as soon as possible and go to their respective doctors in their respective areas, and they need not travel all the way to Bombay, all the way to Delhi, AIIMS, and treatment exists at every place, and at least diagnosis can be confirmed, and then once diagnosis is confirmed, then they can go for treatment anywhere. So I think this is a positive sign that awareness is increasing. Earlier, 1980s, we used to say 80-20 formula. 80% are diagnosed in advanced stages and only 20% get cured.
So I would also like to add here.
Now, Chavi, just one minute. Now we are seeing more than 50% in early stages. So the scenario has changed. Even bilateral breast cancer in the age of 30s, I am seeing now they are at max, and they are coming in early stages and early, ages also. And earlier we used to say after the age of 50 or 60, breast cancer will occur. Now we are saying early ages also people are coming and they are doing well, very well. So that is the advantage of early detection.
So a lot of people, like how I also, my first reaction to the call from the doctor was that it cannot happen with me. Why? Because I had healthy pregnancies, I don't have any history, I have a good lifestyle, I breastfed both my babies. It is not possible. The test is going to be negative. There's no point in doing it and psyching myself. So I just want to tell all the viewers that it doesn't work like that. Medicine may have advanced a lot and we have all kind of treatments today, but we still don't know why it happens to a certain person. So I think it's stupid to just ignore it. And the wise thing to do is get your tests done timely. And as Dr. Julka said, be mindful of the symptoms that you're facing. And there's no harm in going to the doctor and getting yourself checked. Yeah. And even I feel that for breast cancer, the first thing you need to do is just go to a doctor. He will tell you whether you need to get a biopsy done or not, whether you need further investigation or not. But let the doctor tell you that. Don't just, I get so many messages from women who ask me, I have a lump in my armpit, what do I do? Is it cancer? And I feel that you just need to go and visit your nearest doctor and just get it out of your system, for all you know, it's nothing.
Thank you, Chavi.
That is very important. And, people come and say, why me? So this is the question asked, as Chavi has pointed out. But we always say that early detection is absolutely curable, and we are making cancer into a chronic disease like diabetes and hypertension. And you take the pills, targeted therapies are coming in a big way. You take the pills and then you keep on doing your normal work. So that is the crux of modern, treatment scenario.
If I may just come in, I think the idea of screening is actually to pick up cancer even before you're able to feel a lump or you have symptoms. And this applies to a lot of the cancers, especially breast cancer. If there is a lump, it's a no-brainer that you must go see your physician, see your gynecologist, see someone and get your mammography done. Similarly, those who are at high risk, smokers for lung cancer, those having genetic predisposition. If you had cancer in your family, especially on your mother's side, that, especially in ladies, predisposes you. You may be at higher risk. And that's the predictive, genomics, where it helps to know whether those mutations are there or not. So if you have a symptom, please don't ignore. In fact, we are coming to a stage where even without symptoms, a tiny little nodule, which even after it has been diagnosed, you may not be able to feel, that is what we want to pick up. And that's where screening is so very important. And here I would also say it's very important, of course, education at large for the citizenry, for society is very, very important. It's also equally important to educate the physicians, the GPs, the gynecologists, and because they are the first people that someone will go to with a problem, and so their education is also very, very necessary. And our index of suspicion, especially where there are higher risk factors for cancer, the index of suspicion has to be very, very high. Because as Dr. Julka has said, in breast cancer, if you catch it in stage 1, the cure rates are above 98%. So 30 years, 40 years down the line, the lady will die from some other thing, not from the breast cancer. But we can't say the same when it's stage 3 or stage 4. And so it's very important. Screening is very, very, very important. And in the breast cancer context, if we compare rural versus urban India, and these are Indian statistics, the urban woman is nearly at twice the risk of developing breast cancer as the rural women. And in the cities, 1 in 8 women is going to get breast cancer. This is just breast cancer alone. So we cannot ignore a lump. You cannot say कि हम देखेंगे अगले महीने क्या होता है. That's just not on. Thank you.
Thank you, sir, for that.
Dr. Harsh was saying, I think we entirely agree with him. And I would like to point out that, my brother who stays in America, in US, at the age of 40, if you don't have colonoscopy, routinely, you won't be promoted. So that means without symptoms, without anything, routine clinical examination and examination of, the other parts of the body is done in US. Preventive health checkup. We have at Max preventive health checkup. Yearly people come and get it done, and sometimes we pick up early stage cancers. This is what I wanted to highlight.
Sir, absolutely agree. Even simple modalities like pap smears and even like a total PSA test for men above the age of 50, I think are amazing tools when it comes to early diagnosis. And these are fairly simple tests to get done, and you're done in about 5-10 minutes if it's a blood sample or it's a pap smear. So definitely everyone should definitely include it in their annual checks. My next question is to Dr. Mahajan. And in the essence of time, sir, I'm going to include 2 questions that I had for you. And so my first question was about how teamwork or interdisciplinary coordination among different experts is indispensable if you have to reach a correct diagnosis. Might be the pathologist discussing with the radiologist that the cancer marker was elevated, did you see anything on the imaging? Or the radiologist discussing with the oncologist that what is your differential diagnosis, and so on and so forth. So I think teamwork again is very important in any oncology patient's journey or treatment. So the second one I think would be that this discussion would be absolutely incomplete without touching upon how the world of imaging and oncology has leveraged technology, and especially now that we are in the world of AI and machine learning, what are the latest advances that you've seen in the world of radiology? So if we could get your comments.
Thank you, Arjun. These are both very, very important questions. As every field of medicine has advanced, our vision becomes more and more tubular. So I know a lot about my own field. The oncologist knows a lot about his own field. The pathologist knows everything about his field. The nuclear medicine physician knows everything, but we know very little about each other's field. Whereas we have to look at the patient as a whole. It is not a CT scan or a PET scan or a lab test. So it is very, very important that we talk to each other. And this has become much simpler now with the advent of technology. We are ourselves, having this discussion on digital media. And so many people around the world are able to see us. So similarly, this interaction needn't be physical interaction. It may be online interaction where the entire team, even though not physically present together, that in today's day and age may be tough, but they can be together, and there are technologies now available, platforms, digital platforms available, where on the same platform you can upload the X-ray images, the CT, the PET CT, the histopathology, the biopsy report, and all of that, and discuss everything together. So this is indispensable. In fact, I'll go ahead to even say that soon in the next 5 years, we are going to have a new branch of diagnostics which is going to be the branch of integrated diagnostics, because it has become very difficult for the treating doctors to assimilate so much of information and data which is coming from diverse sources. So we would need a layer in the middle where an integrated diagnostician is able to kind of digest all the data, make sense of it, and then tell the treating physician how to go about treating the patient. And here, artificial intelligence is going to play a major role, because even for one person, even trained very well, it would take a lot of time to make sense of so much of data. There are thousands of images. There are so many genomics markers. There are so many lab tests. So I think this middle layer of integrated diagnostics is essential, which will be able to make the task of the physician, the oncologist, easier, so that he is able to concentrate on treatment and not have to spend time on trying to understand what the diagnostics is. Of course, he will need to know that, but he doesn't need to go into the nitty-gritty of everything. He needs to be presented, and that's where artificial intelligence will play a major role. The other area where artificial intelligence is already playing a role, and at Mahajan Imaging, we have the startup which came out of Mahajan Imaging, which is called Kapul.ai, where we've developed a platform where you can take AI algorithms which actually help the radiologist in making very quick diagnosis more accurately in shorter span of time and with lesser mistakes. So your productivity increases, as well as the accuracy increases using AI algorithms, which currently we use for chest X-ray, we use for chest CT to look for any early malignancy, X-ray mammography, and more coming. I think in the next 5-7 years, these are going to become part and parcel of how we diagnose disease, and they are also coming in histopathology, where again, a doctor needs to look at the slide. Here, the AI algorithm will be doing a similar task, and the time is not far, where for a large part of the work, the artificial intelligence algorithms will take over. So while we are seeing so many bad things about artificial intelligence in other facets of life, in healthcare, as things exist, I think artificial intelligence will play only a constructive role. It'll, as I like to say, it'll make an average radiologist good and a good radiologist excellent. And also, I feel that in the future, radiologists and maybe histopathologists with AI probably will replace radiologists and histopathologists without AI. So I think AI is already starting to play a very constructive role, and there is no looking back as to its use in a positive manner, in improving precision medicine, in improving precision diagnosis, in telling us how so much of data can be assimilated to make sense, so that the oncologist or the treating physician or surgeon can decide on the correct line of treatment.
Thank you, sir. And sorry to be cutting in, but we only have a couple of minutes, and I just want to also ask a question to Dr. Sen. And ma'am, so again, with respect to your specialty of nuclear medicine, there's a lot that's being spoken about patient safety, and also how important it is that the benefits outweigh any kind of potential risks. And also in the field of theranostics, also nuclear medicine is extremely important tool now. So if we can have a quick response to this from you, and then we'll move forward.
Yeah, thanks, Arjun. So patient safety is paramount in any medical modality, and especially so when we talk about diagnostics, because first, do no harm. That is the dictum which should govern everything that we do. And fortunately, technology has played a very important role in these kind of situations. So you have now newer machines, the digital PET CTs. The digital PET CTs allow us to do the scans with almost half the amount of radioactivity which we had to inject earlier. So the patient, if earlier had to be injected with X amount of radioactivity, today the same scan can be done faster. Earlier, a scan would take 20 minutes. A patient who's claustrophobic, for him to be in that machine for 20 minutes was a nightmare. But today, with the newer machines, we have a digital PET CT scanner at Fortis Gurugram, which allows us to do a scan in just about 3 to 4 minutes and with just half the amount of radioactivity. So again, these are the things, and they give us brilliant images. So the images, which the resolution of the images, it allows us a lot of quantification, which we could not do earlier. So even earlier, anybody who's had a PET scan would know that it's important that the blood sugar has to be kept at a normal level for doing a PET scan. And often the reports of the PET scan findings in a patient who was diabetic would be distorted because his sugar levels would interfere. But today, with these newer techniques, you can do parametric imaging, which will allow you to give you an accurate quantification, even if the patient's sugar levels are not high, are high and not controlled. So all these factors help in giving the patient a much safer investigation, in giving more accurate information despite the changes in physiology, and improving the patient's experience as he goes through these imaging modalities. The second aspect is of theranostics. Now, theranostics is an amalgamation of two words, therapy and diagnostics. And while this concept is not unique to nuclear medicine, it is used very often in the lab, it is used in molecular medicine. It is theranostics in nuclear medicine has probably been used very often, and in the last couple of decades has become the center point of what we do. Now, what happens here is that you have two molecules. One molecule which looks at the diagnostics using a particular receptor or a particular way a tumor behaves, and you have a sister molecule or a partner molecule which actually goes and attaches to the same receptors which the diagnostic molecule had picked up. And because this is a radioactive substance, it gets incorporated, internalized in those tumor cells, gives local radiation, and gives the most targeted radiotherapy which is possible in this kind of a situation. So in a patient who's got disseminated disease, who's got disease all over, using the theranostics concept, we can actually target each of the cells which are disseminated in the body, get our medicine to go and attach to those cells, give local radiation by virtue of it being a radioactive substance, and hence control the disease. So the concept of theranostics is changing the way therapy is done today, not just in nuclear medicine, but in various other modalities. But in nuclear medicine, it allows for a very personalized and individualized kind of treatment without damaging the normal cells, which is very important. So you can seek out single tumor cells without damaging the normal cells around it. So you have different therapies which are there for different tumors, for different kinds of cancer, which are especially used in patients who are in advanced disease, where if you try to treat them by external therapy, you're going to end up irradiating or end up damaging a lot of normal cells, normal tissue. But by using these theranostic molecules, you can actually target the cancer cells, treat them, and without damaging the surrounding normal cells. And that is why this is called the magic bullet therapy. And magic bullet therapy works in precision medicine. And as Dr. Mahajan said, all these techniques have to come together. They come together and they help in treating a patient, giving him better survival, better outcomes, better quality of life. And that is what the future of cancer therapy is going to be.
Thank you, ma'am. Thank you. I wish we could talk for longer, and so many other questions that I would love to ask everybody and learn from everybody here. But my apologies, we are short of time and we need to conclude. And I would like to express my sincere gratitude to everyone who has joined us today. And as we conclude this conclave, let us carry forward the knowledge, insights, and inspirations that we've gained today from Dr. Mahajan teaching us more about the Brahmastra, to Julka sir telling us about the molecular horoscope, and to Dr. Sen also telling us about this magic bullet. I think there's so much more to be learned, and I think Chavi's statement that said that if once I can't conquer that, there's nothing else that I can't conquer. I think what doesn't kill you does make you stronger, and I think it's very enlightening to have everybody here. And since we are short of time, we would like to conclude, and thank you everybody, and thank you TOI.